Welcome, everyone. Thank you for joining. We will be starting shortly. Thank you, everyone, for joining. We're waiting for everyone to log on. We'll be starting shortly. Welcome, everyone, to today's webinar. We are so happy to have you here for Care and Choices at the End of Life, Hawaii's Our Care, Our Choice Act, the role of the nurse navigator. My name is Sam Trad. I am the Hawaii State Director for Compassion and Choices. As we begin, I need to read the requirements for the continuing education credit, so bear with me. I need to read this to make sure you all get credit for taking this webinar. In support of improving patient care, this activity has been planned and implemented by the Hawaii Pacific Health and Compassion and Choices, Hawaii American Nurses Association, and NASW Hawaii Chapter. Hawaii Pacific Health is jointly accredited by the Accreditation Council for Continuing Medical Education, the Accreditation Council for Pharmacy Education, and the American Nurses Credentialing Center to provide continuing education for the healthcare team. Hawaii Pacific Health designates this live webinar for a maximum of 1.5 AMA PRA Category 1 credits for physicians. Physicians should only claim credit commensurate with the extent of their participation in this activity. Hawaii Pacific Health designates this live webinar for 1.5 contact hours for nurses. Hawaii Pacific Health is accredited by the Accreditation Council for Pharmacy Education as a provider of continuing pharmacy education. This activity is accredited for 1.5 contact hours for attendance at the entire CE session. As a jointly accredited organization, Hawaii Pacific Health is approved to offer social work continuing education by the Association of Social Work Boards, approved continuing education program. Organizations, not individual courses, are approved under this program. State and provincial regulatory boards have the final authority to determine whether an individual course may be accepted for continuing education credit. Hawaii Pacific Health maintains responsibility for this course. Social workers completing this course receive 1.5 continuing education credits. Hawaii Pacific Health is accredited by the American Psychological Association and designates this live activity for 1.5 continuing education credits. Continuing education credits for psychologists are provided through the co-sponsorship of the American Psychological Association, Office of Continuing Education in Psychology. Hawaii Pacific Health maintains responsibility for the content of the programs. In order to claim CE credit, please note that to receive continuing education credits for this offering, you must claim credit commensurate with the extent of your participation in the activity, complete and submit the evaluation survey that will be emailed to you within 1 week of the offering. Speakers cannot claim credit for their own presentations. Your CE certificate will be immediately available to you upon completion of your evaluation. Thank you all again for joining us. We are so happy to have you here today. To ask a question, you can ask a question at any time during the presentation by putting your question in this box. At the end of the presentation, we will get to as many questions as possible. The way we do it is we copy and paste your question into a Google Doc because we get a lot of similar questions so that we can try to merge them so that we get through all of them at the end of the presentation. So if it says your question has been dismissed, don't worry, it isn't really dismissed. We will get to it at the end. This presentation is being recorded. If you're not a presenter, don't worry, we can't see you. You're welcome to go on eating French fries or whatever, and no one can see you, but it is being recorded. We are very honored to be joined by the following speakers today. We are joined by Susan Amina, nurse practitioner with Kaiser Permanente, Michelle Cantillo, RN, Advanced Care Planning Coordinator for Hawaii Pacific Health, Jody Shaw, licensed social worker, CCM, OSWC, APHSWC, Kaiser Permanente, and Dr. Chuck Miller, physician specializing in hematology, medical oncology, and program director for Kaiser Hawaii Aid in Dying program. We are here with Compassion and Choices. It's one of the oldest nonprofit organizations dedicated to improving care, expanding options, and empowering everyone to chart their own end-of-life journey. So who is here with us today? We have our first poll question, and we would love to know a little bit about you, what your profession is. So if you could take a minute and fill out the poll and let us know what your primary role is. Are you a registered nurse? Are you a physician, a social worker, an APRN, a pharmacist, pharmacy technician? We will wait just a few more seconds. All righty, let's end the poll. And can you show the poll, please? All right, well, it looks like half of you are registered nurses. We have a few APRNs and social workers. Thank you all for joining us today. The objectives for today, we want to review clinical competencies for participating in medical aid in dying and requirements of the law, examine the role of nurses, APRNs, advanced care planning coordinators, and medical aid in dying. So important. And finally, examine the team-based approach to patient-centered care. So let's go ahead and begin with where do we start? And I will hand it off to Dr. Miller.
Okay, thank you, Sam. This is a question I think that every provider, doctor, nurse, or whoever you are, should be ready to face. Just when a patient comes to you and requests aid in dying, you need to explore what you believe about that. Where does that go in your mind? And on this slide, I've put there 3 different times, listen, listen, and listen, because that's the most important thing you can possibly do to help you understand the patient, why they are requesting aid in dying, what concerns they have, their relationships. Certainly, one of the big recommendations is that they discuss this with their next of kin for sure. And then finally, look at the last line. Even though it's not required by law in our aid in dying law here in Hawaii, if a healthcare professional has their own ethical issues or moral issues that they don't feel that they can participate in a patient's request for aid in dying, then my feeling very strongly about this is that they have a moral obligation to refer that patient to a provider who is willing to help them. Next slide. Okay, this is something that I'm sure almost all of you are very aware of and know. What are the options for end of life? You see them, you can keep going with life-sustaining treatment. You just stop. You can refuse it. You can go get palliative care, which is difficult to do on an outpatient basis, at least in our state. There is a thing that is legal in every state in the union. The patient can voluntarily stop eating and drinking. I personally don't recommend it because it can take up 4 to 8 days for this. Continuous deep sedation is what is usually done in an inpatient hospice setting because it requires intravenous sedation with either morphine or some other drug that puts the patient to sleep and basically they don't wake up. Most of the patients, certainly cancer patients, end up being in hospice during their last 6 months or 5 months or 3 months or however it is. And then medical aid in dying is just one of the options that's now available in 11 different jurisdictions throughout the country. I think New Mexico just passed, they're the most recent state to pass legalizing aid in dying. So next slide. So what is it? Well, it's a standard of care. There are clinical practice guidelines and standards of care published for medical aid in dying. And virtually all of the state laws say that a patient who is medically capable, he has to be an adult, by definition that's over 18, and a prognosis of 6 months or less to live may request a doctor's prescription for medicine, which they can choose. They have to be able to self-ingest it, and this allows them to end terminal suffering in a peaceful way, usually almost universally at home with their family's support. Next slide. So our law has several requirements. First of all, it has to be a terminal diagnosis that they have, and we talked about the prognosis should be less than 6 months, 6 months or less to live. The law does not require them to be in hospice to avail themselves of aid in dying. And then the 20-day survivability, we've had that a big issue here. Probably a third of patients who request medical aid in dying don't live long enough to get to the 20-day requirement. They die before they can even become eligible. They have to have the mental capacity to make that medical decision, that specific medical decision about requesting aid in dying, to understand what it means when they request that. It certainly has to be voluntary. We've never had any instance I'm aware of any state where there's been coercion discovered. They have to be able to self-administer, and they have to be a resident of the state of Hawaii. Next slide. So the requirements are they have to be able to make 2 oral requests 20 days apart. The first one to the attending physician, and you can do this in person, telehealth, or even by phone. And then they have to make another second oral request 20 days later. It has to be at least 20 days. It can be 21, 22, whatever. They have to make a request to one other physician, that's the consulting physician. And they have to put in a written request that is signed by 2 witnesses, one of whom can't be related to the patient, and a member of the healthcare team who is taking care of that patient cannot serve as a witness. Next slide. So the attending physician, this is the provider who will write the prescription. So when I'm doing this, I evaluate the patient, ensure that they meet all of the requirements for the law, and I document this on Department of Health forms as well as in their medical record. We follow the compliance process. And then after 20 days, if they have seen the consulting provider, if they have had their mental health evaluation. They've completed the written request and they've done the second oral request. Then I can write the prescription. I'm not going to talk about the APRNs. We had a law in the legislature this year that would allow them to serve as either attending or consulting physicians, and it did not make it through. I'll let Sam talk about that later. Next slide. Okay, the consulting physician, basically his job is to say, he evaluates the patient, does the documentation required, but basically his job is to say, I agree with Dr. Miller with the attending physician's evaluation. That's really what he's doing. That's what the law requires. And then the third thing, which only Hawaii requires, is a psychiatrist, psychologist, or licensed clinical social worker has to make a separate evaluation of the patient's mental capacity to make this medical decision. Most of the psychologists that I have been associated with in this, they think this is a redundancy. It's unnecessary. Next slide. Let's talk a little about the death certificates. Obviously, you see it establishes death for legal and state purposes, but it's also for public health statistics. The important thing to remember, in a patient who dies from medical aid in dying, the cause of death is a terminal disease that they were trying to escape from. It is not suicide, homicide, or anything like that. The manner of death is considered natural, or I guess there's a spot on the Hawaii death certificate for it can be other. Next slide. So let's talk a little bit about what else the law provides. It provides significant professional protections. First of all, no healthcare provider is under an obligation or duty to participate in the law if it is against their ethical or moral beliefs. Also, no liability can, nobody can be sued if for any, as long as every member of the medical team is acting the way they're supposed to and fulfilling all the requirements of the Our Care, Our Choice Act. And historically, we know there's never been any disciplinary action taken against a doctor or a nurse or anyone else for either for participating in aid in dying or declining to participate. And next slide. So taking aid in dying does not affect the health or life insurance status, or for that matter, any other legal or medical contracts according to the law, by law in the state of Hawaii. And I said this before, it does not constitute suicide, killing, homicide, anything like that. So next slide. I think that's back to you, Sam.
Yes, thank you so much, Dr. Miller. Next, we're going to talk about the role of the nurse and social worker. And I'm so glad we have so many nurses and social workers on here because your job is so invaluable. But I think to better explain it, I will be handing it over now to Susan Amina, who is a nurse practitioner with Kaiser. Thank you,
Great,
Susan.
Pam. Yeah, so from a Kaiser perspective, we wanted to kind of review what this looks like from the beginning of the first interaction, setting up appointments, a little bit about the forms, the documentation, handouts, and telephone follow-up. And just note, I mean, different terms are used in different organizations. So you might hear a care coordinator, which is actually what term we use at Kaiser. You'll hear nurse navigator, patient navigator. This certainly can be played by the role of the nurse or the social worker. Certainly in the interim, so hopefully someday the advanced practice RN in Hawaii will be able to be the attending or consulting provider, but in the interim, certainly an APRN can be that in that role as well. So I'm going to actually turn it over to Jody to cover the next couple of slides.
Hi, everyone. Good afternoon. I'm Jody Shaw, and I'm the oncology social worker here at Kaiser. And so Susan and I are the co-coordinators. We're patient coordinators here at Kaiser, and we share the responsibilities. So we try our best. We sort of take turns on as the referrals come in, and then we walk the patient and the providers through the process. Could I have the next slide, please? So for Kaiser, it's really wonderful. Like it was all established. All the different departments got together, before the law went into effect and set up, all of the different processes. And there's so many different areas that are involved in supporting the patient and family through this process. So the first step is Susan and I would get the referral from the doctor. It's typically the specialist or the primary care doctor. We get that referral through Health Connect. And then upon receiving it, we'll study the chart and see if they're on Oahu or a neighbor island, and then reach out to that patient or family to set up our first interaction or meeting with them. So if they're on Oahu, ideally we'd love to meet with them in person. It's so important, or it's so much more meaningful, I think, having these conversations and interactions in person, or at least being able to see them through a video and, seeing their facial expressions and emotions. And it's such a, sacred topic and time in their lives. And so ideally, we'd love to meet in person. Of course, last year that wasn't possible, as much, but that's our goal, and we hope to get back to that for all of the patients. So Susan and I will set up a coordinator meeting or evaluation with the patient or family, and really try to get to know them and what's motivating, like Dr. Miller was saying, what's motivating them to choose and to ask for this option. And also, what is their support system like? And are their family aware? Are they on board? And definitely trying to explore all of the different other options and supports that Dr. Miller also mentioned. So, and if they're not on hospice, we highly recommend hospice and would love for them to have it hand in hand with with pursuing this option. So I think for most of our patients that we've had, there's only been like one or two that have not had hospice. And we just find that such an important piece, and that to have their team and support on board to support these patients and families. So basically, what Susan and I do is we really walk this patient and family through the process and help them navigate through it. So we do, review regarding the eligibility, the timeline, the different steps. For the patients, there's two forms that are involved. One is the written request, and then there's also what's called the final attestation form that they complete. It's within 48 hours prior to taking the medication. And the written request, that one is completed after they meet with all three of the providers. We start to talk about the medications that are involved. So right now we're utilizing the DDMA, and then we do set up all of the appointments. So with the attending, with Dr. Miller typically, or a specialist, with the consulting provider, and then with the mental health provider. And we have a really great guidebook, and we'll see that later. And on the last page of the guidebook is all of the different steps, like clearly laid out for the patient. So that's a really, really helpful page for them, because it can be overwhelming. There's all these steps and requirements, but we try to just break it down and make it as straightforward as we can. And we always reassure them that just call us, just call Susan and I if you have any questions along the way. And, we'll just walk with you step by step on this. And definitely, it's more than just someone taking them through the steps. It's being there to provide the emotional support. And oftentimes it's also for the family members. And, I do see a lot of family members that they just love their family members so dearly, but they're conflicted about this too. And it's hard for them to sometimes play this role and be supportive, but they want to be there for that person and make their wishes a reality too. So it's supporting the family, the patient, and then also the providers that are involved. We also will be involved sometimes in identifying the providers. Like, for example, if they're on a neighbor island and we need the consulting provider who's typically the specialist, we'll have to figure out who that will be and then reaching out to them and setting that up. And then we have like a tracking system as well. We have a spreadsheet that we've established and put in all the different dates. So, Susan and I and other staff can look at that if needed to see where a patient is. So, and that's really important too. Next slide, please. Okay, so a little bit more about the appointments and the forms. So as much as possible, I'd say Susan and I really try to schedule the provider appointments as quickly as possible once we get the referral. And it's just very reassuring to the patient and family. And, as Dr. Miller mentioned too, we have seen a number of patients that have been referred later in their disease process and closer to the end. So sometimes just, going through these appointments and trying to get through the process in itself seems to be palliative for the patient and family and reassuring too. So we do try to, get things set up as quickly as possible. And especially if they're, they're on the decline and not doing so well, or maybe they're an ALS patient and their ability to swallow is decreasing, as well. And then again, after the patient completes all 3 of the provider visits, then they would complete and send in the written request. So we just, remind them of that. And oftentimes they have questions too, because there's 2 witnesses that are required for that form as well. So just helping explain, that and answer any questions on that. And then definitely for high acuity patients, we really want to try to have this done as quickly as possible so that we do have we've received the written request at least 48 hours prior to the second verbal. So for the written request, once we receive it, by law, the attending provider has to wait 48 hours before they can write the prescription. So that's one of the requirements or time requirements, in addition to the 20 days between the first and second verbal. So ideally, we've received the written request, well before 2 days prior to when the second verbal request can be done. So if that's all taken care of, then medications can be written on the same day as a second verbal request. So the doctor would call the patient, do the second verbal request, confirming they want to continue with the process. And immediately after that, the doctor can then write the prescription for it, and patient can pick it up pretty soon after. And then for the forms, we ask that the patient and family return it to Susan and myself, and we provide a self-addressed stamped envelope for them. And we double check the forms to make sure it's accurate and complete, and we mail it. And the Department of Health asks that we mail all of the forms together you know, to them for that patient once the prescription is written. So that'll be, you know, so the attending, paperwork, consulting, counseling, and the patient's written request as well. Okay. And the next slide, I think I'm going to hand it over to Susan.
Thanks, Jody. So to talk a little bit about the Navigator's documentation, at Kaiser, what we did is we actually completed or created templates. So we've got one for the Navigator as well as for the attending and the consulting physician, as well as for the second verbal with the attending. So just very helpful in terms of, you know, expediting documentation, making sure that you've got all the required elements. And then of course we add to it, you know, Jody and I add to it in terms of details in regards to this specific patient and family. Now, no, again, it's a little bit different than in the community. So we're actually doing this first interaction, patient education, prior to the first verbal request. And, you know, sometimes I'll say that we have found that even though the PCP does kind of a superficial review and sends us a referral, there have been a few occasions where when we do a chart review and we talk to the patient, you know, it appears that they may not meet criteria in terms of that prognosis. So then at that point, we actually consult with a specialist and the process may be deferred based on that opinion. So we're going to look at the template in just a bit. And then of course we make hospice referrals, as many of you are aware of, in terms of sending medical records to hospice and a summary of patient's medical condition. And then for telephone follow-ups, through this whole process, we're doing reminder calls. You know, we recognize that this is a lot of information. It can be very confusing on who's who and what's next. And so we really try to reassure the patient that, you know, that's our job. We will remind you, we will track on the time frames to meet the letter of the law, that's not necessarily, this shouldn't be burdensome in terms of the process. And then we do periodically, once the medication is picked up, and of course, you know, patient's choice in terms of whether they want to take the medication or not. But, you know, we periodically call them and just check in, you know, depending upon acuity, it might be every couple of weeks or monthly, just to say, hey, you know, we're still here, any questions, and provide support as needed. So next slide, please. So this is a template, which is obviously fairly hard to read. But again, just kind of, we're looking at Indeed, trying to verify, although a little bit more difficult by telephone, but are they a Hawaii resident? Do they have any cognitive impairment or behavioral health diagnoses in the problem list? Are they currently enrolled in hospice? You know, we do a chart review to see, have they completed a pulse or advanced directive? And then just documentation of what we reviewed. And as I say, this is just kind of a guideline. You know, our notes are typically lengthier than this because we're talking in great detail in terms of why is the patient considering this and what type of support systems do they have and any specific concerns. If we're face-to-face, we're obviously giving the patient the guidebook that Jody's going to talk about, and the forms needed to be completed. If not, we mail them in advance. So again, just nice to have, again, for just kind of speed along the documentation process and then to add as needed. And then I think sometimes it's helpful too, just to put down patient quotes. Sometimes that's really helpful in terms of getting a sense of what's going on. I had an interaction this morning by telephone with a patient in Hilo, and you know, she had some interesting comments about why she's considering this option. And so sometimes I think that's really helpful to put that down in quotes for other readers of the note. And then I'm going to pass it on, if we can, next slide, and talk about the materials that we give to the patient. And Jody's going to cover this.
So this is our patient FAQ sheet on the MAID option here at Kaiser. And this is available to all staff on the KP Health Connect homepage. So it's under the patient handouts. So, you know, we try to spread the word and let all staff know that it's available there. So if someone expresses interest or has questions about the MAID option, please give them this sheet, and then it directs them to contact their doctor, their PCP or specialist, if they want to find out more about it in detail, or if they are interested in it. So that's so that's where we encourage all staff to start if a patient does express interest. Next page, please. And then this is it's a cover of our guidebook, the medical aid in dying. And I have to give credit to I think it was it Southern California or Northern California Kaiser. We based this a lot on their existing guidebook, and then of course tailored it and to Hawaii, or Hawaii patients here. So this is a guidebook that we give to a patient when Susan and I meet with them for the initial educational visit. And Northern California, thanks, Sam. And again, on the last page of the sheet is a checklist, and it really just lays out step by step. So some other steps that we do here at Kaiser's, for example, once Susan and I meet with them, we make a referral and a request to the financial counselors and pharmacy administration. And what they'll do is they'll research what the cost will be for the patient for the medication, and then the financial counselor will call the patient or family to let them know, right up front, so they know what the cost involved is. But it seems like it's not typically more than $200 something at this time. And another step is that we have the patient or family meet with our oncology pharmacist after the medications are prescribed. That's another step that we set up, and they would meet with the pharmacist to go over how do you mix the medications and what to expect. And we have there's a great handout too with instructions, so that they can take this home and as a guide at the time. Next slide, please. Okay, so we just wanted to share a couple of stories. We've been doing this, this is our going into the third year, and one of the patients that really stands out to me is Larry, who was a 65-year-old gentleman here on Oahu, and he had a head and neck cancer. He was actually diagnosed in 2013, and he went through numerous types of treatments, chemotherapy and radiation, and he did end up getting a PEG tube, and so he was diagnosed in 2013, and he was a survivor and a fighter, though, and very feisty gentleman, full of life. And then when the law came into effect, he started to study up, and in July of 2019, he actually came to an appointment with his physician's assistant, and he brought like a binder with the law printed out and the forms that he found on the site. And he he was a man that was very much in control of his life and his destiny, and this is what he wanted for himself. And he was ready to, he brought his own forms, and he was ready to get things started. And so we, started on this process with him July 2019, and he was able to, go through the process and pick up the medication at the end of July. And then he began to decline further and lose more weight, and so he wanted things to, his ending to be, defined by himself. And he was so funny too, because he was very directive to all of us involved. So he wanted me to be there, and Dr. Beal, his oncologist, And then Bristol Hospice was also involved, and he asked for his nurse and one of their directors to be there, who had met him at the beginning too. And he said, you have to be there by 7 o'clock, no sooner, no later. We were actually waiting at his door at about 6:55. He let us in at 7. And, so he wanted us to be there when he took the medication. And he has 2 sisters, so they were there as well. And it was really lovely. It was like a little celebration of him. And he was able to share a lot of stories and memories. They were able to reminisce. And then he was finally, ready to take it. And he fell asleep within a couple of minutes and passed, I think it was about 45 minutes later. And he administered it through his feeding tube. But it was just, he was so thankful to be able to do this on his own terms and the way he chose. So that's just a story I wanted to share that stands out from the patients. Okay, next slide, please. And I think I'm handing over to Susan.
Great, thanks, Judy. Yeah, we've got lots of stories. Actually, we could spend the hour and a half just talking about different cases that we've had the privilege of working with. Just a note about, again, the nurse navigator or social worker navigator. The process, of course, is going to change based on the healthcare organization. And I think Michelle will talk soon about, HPH's process. But, a lot of times community processes have been where they actually educate after the first verbal request. So it's really whatever's going to work best for your practice. Again, as Jody mentioned, we tend to do our education first after we're the first ones to receive the referral, and then we process it as quickly as we can. So again, just kind of based on what's going to work best for your organization and what makes sense to your patients. So next slide. This is just a little bit of data from the last couple of years. We've had a lot of referrals. 85, pretty consistent from 2019 to 2020. Majority of those diagnoses have been cancer. Pretty split between the Big Island and Maui. There was 5 patients that actually were ineligible, 3 because they didn't meet that 6-month prognosis. So what we typically do is just kind of put them on hold and touch base with them and the physicians in terms of when that patient may be meeting the prognostic criteria. And then 2 that didn't actually have mental capacity and weren't able to proceed at that point. 39 prescriptions had been written, 61 people had passed, and 25 for those 2 years were from medical aid and dying. As Dr. Miller alluded to, the concern is, we had a number of patients that actually died waiting for that 20-day window period to pass before they could make the second verbal request. So that definitely is a concern that hopefully we can address in future legislative sessions. And then just a little bit about 2021. So to date, we've actually received 17 referrals. We've had 2 May deaths. One of them actually was from a 2020 referral. So far, we've actually had 4 from the Big Island and 1 from Maui. And then we've had 2 that have been ineligible, 1 because of mental capacity and the other because actually the individual was not a Hawaii resident. And then we've had 8 natural deaths. And then again, 4 died before that second verbal. So, part of it too is just trying to work with the specialists and the primary care providers to send referrals earlier rather than later, just so that we can jump on that and avoid not meeting the wishes of the patient who's choosing this option, but then isn't able to meet it because of that waiting period. And then next slide, please. So just talk a little bit about our transition. So as Jody had mentioned, we had a lot of work up front before we implemented with task force and operational work group. We've got an algorithm and we've got a lot of documentation around the workflow and the policy. You know, we've tweaked these documents over time based on changes and improvement in processes. We've integrated the Quest workflow now that group is covered in terms of medications, and there's some additional forms that need to be completed for that group. We definitely have improved our time from referral to dispensing medication. I think we've been able to streamline that, and really the constraints are based on the law. We have improved our hospice partnership, and we definitely have more communication with them. They keep us abreast of what's going on. We kind of keep them up to date, especially when the medication has been dispensed. The deaths that I have attended with Dr. Miller, one death was actually just the two of us alone, and that was the patient's choice. And the other one, actually, they wanted everyone. They wanted hospice and they wanted Dr. Miller and myself. So again, it's been a real partnership and a learning on both ends. And then we've had an increase in physician participation, both for the attending and consultant roles in terms of primary care providers and specialists. So, you know, that certainly has been helpful. And we, during this period, started dispensing medication. Initially, it was only on Oahu, which was very burdensome, because then family actually had to fly to Oahu to pick up the prescription. So now it can be dispensed at the Hilo Clinic, Maui Lani, and the Kona Clinic. We have transitioned from the medication DDPM2 to DDMA, where you're replacing propranolol with amitriptyline. I think we have seen a little bit quicker time to death. I have to say there was one patient recently with DDMA who took 2 hours, and then another gentleman that was 15 minutes. And both individuals were actually very petite, tiny. So we are seeing a bit of a difference, but prior to that, we are seeing less than an hour with a couple other patients with DDMA, which is nice for the families, right, and those that are participating, because it's pretty agonizing after that patient's fallen asleep and now waiting for that patient to actually die. And then, as I alluded to, the challenge is really timing of referrals. Certainly would rather get a referral earlier rather than later, that we can at least put on hold, versus getting a referral so late that you're not meeting the request of that patient. And I think next slide is going to pass it on to Michelle.
Next slide. Thanks, Susan. Thanks, Jody. That was brilliant. Thanks for sharing all your information. I want to steal some of your ideas and suggestions, all your phrases, your guidebooks and things like that. That's awesome. I wanted to start out, but I'll talk about, my name is Michelle Cantello, Advanced Care Planner Coordinator for Hawaii Pacific Health, and I'll talk a little bit about my role, and more importantly, the role of the nurse navigators and the social workers for medical aid in dying. And before I start, I want to share Judy's story. So Judy has given us permission to share her story with you guys. Judy Browning, she died last year, COVID times. And she came to us back when she was always looking at the law back in 2018. And she has breast cancer. She had it back in 2010 and it metastasized, got really bad where it advanced to her axillary area. She had a huge ulcer over here, and it also invaded her heart. She had a tumor in her heart, to the point she did go to the mainland to see if she could have it surgical removed, but she was unable to do this. She was a lady full of life, joy. She's from East Coast, from Connecticut, and she's a piano teacher. She loved to have her friends over. She's been married 3 times. Her last husband died of cancer, and so she was aware of hospice with him. So when she had her cancer got metastasized and wasn't doing well, she went to her PCP. Our PCP at Straub, and she's said, hey, doc, I'm interested in this law. She was already with the Hemlock Society as well as Compassion Choices. So she did her homework and she said to him, I'm interested in this law in 2018. And the PCP was said, okay, Judy, let me hear your story. And then he says, you know what? I'm not really comfortable with it right now, but what, like Dr. Miller say, what can we do? Don't just shut her off. Let me put you in charge of another physician who maybe can help you. And that was our palliative care physician, Dr. Manai. And Dr. Manai, back in May of 2018, just worked with Judy and said, okay, Judy, you know what? I don't even know much of the law myself. I have to do some homework. And so, and then together with me, we worked together because Judy's like, what is HPH doing? What are we using? What medications? So we had our homework to do basically from Judy. And as Judy progressed, the reason why she wanted to do medical aid in dying, as well as Susan said, it's good to put quotations as to why, because that's really important. Her mom had cancer back in the 70s, and her mom had wanted to go using medical aid in dying, death with dignity. And she begged Judy, actually, she said, I want this, Judy. And Judy's like, I can't do it. Mom, it's not the law. So mom did pass from cancer, but not, again, it was illegal. So it was always at the back of Judy's head. So 2018, she told us she got palliative care. We worked with Judy. And basically later on, she went into assisted living community, the assisted living skilled facility. Here was our homework. What she taught us again was like, she says, hey, can you guys ask the assisted living where I work if they would permit this law? This is now 2019. And we're like, okay, let's try. And so we talked to that assisted living skill facility, and they were very open, welcoming. What we end up doing with them is, like, I think with Judy's journey, we had about 3 education webinars with them. The first time was saying, hey, this is what the law is. The second time is basically with the whole staff that was involved in Judy's care, as well as a social worker, the nurses, and the assisted living leadership came. They had their own ethics meeting to see how they can move forward. And then we had another meeting when in 2020, Judy did say, yes, I'm really interested and want to move forward, because she was declining. You know, the pain was getting worse and things like that. So for her, when she lost that joy that she was not able to function well, she wanted then to move forward. And that time with COVID, then we had to have another Zoom with assisted living community and facility, and said, okay, here's what Judy wants. She wanted to have her friends. She wanted to die at sunset. She had very specific, she worked with a death doula. That was another thing for Judy on her side. She had her homework to do, and she wanted, you know, the plumeria flowers. She's got her flowers here, as you see, her tulips here. These were very important. She was a piano teacher. She wanted to have music. She worked with, she said to us at HBA, at Straub, can I talk to your chaplain? Because that was earlier on in 2019. Sir, we don't have an outpatient chaplain. And she wasn't 100% enrolled in hospices yet, but we had our inpatient chaplain work with Judy. And then later she rolled on with the other hospice. Then she worked with Bristol Hospice chaplain towards her last part of her journey. So that was all of her homework that she taught us to do. And not only that, with assisted living, you know, we had to work during the COVID times. And during the COVID times, she wanted to have those 10 people, and she was listing all of them, and then including her doctor, including her death doula, including in the hospice, you know. And we were like, it's lockdown. How can we manage this? And I'm thankful, so thankful again to the assisted living that they were able to accommodate the empty condo, right, which is right across, that they can allow people to come and say their goodbyes. So she really, really taught us a lot. She also got involved with getting her will done, her UH will body program. So she wrote a message to all the residents about what she wants, you know, a year later after ashes are scattered. And if you go and Google her obituary, you'll see that she also wrote her obituary. And it's amazing. What amazing woman she is. She's like, if you're reading at this time, you know I have passed and my time has come. So a beautiful person's spirit, and she taught us a lot. Next slide. So what is my role? I am a registered nurse. I've been doing advanced care planning for HPH for over the last 11 years. And much like what Susan had mentioned, my role for the 4 hospitals was create the policy, the process, and basically be the backup person. I'm at the back, collaboration. What's important, even if you're not in a big organization, even if you're in a small clinic, you need to know who will support me as a nurse, you know, a physician, that I may want to do it. And if there's nobody in your team, who can I reach out to? So know that. So I helped one of my oncology doctors was in Maui, and one of the other physicians was willing to help her patient. And she says, I really don't have anybody. Can you guys help me? And we're like, yes, absolutely. We've walked this process. Let's join hands together. Let's collaborate, and we will help you. And we worked with Maui Hospice as well. And the same thing with that nurse, it was her first patient. So know who's your team and how you can support them. Because again, this law is really new. Reach out to us. We're here for your help. Our phone numbers are there. That's what we're here for. And much like what Suzanne and Jody said, work within your system, get it on what's available that staff can say, here, I can go on the medical aid and dying internet folder. What's marketing can do? You know, again, we have our HPH flyers for the patients as well, Q&A questions, and work within the system of documentation. Our roles are a little bit different. Sometimes our nurses and nurse navigators are not the ones getting the referrals. It usually comes, I would say about 90%, the patients go to the doctors, and then the doctors come to us, to me, to the nurse navigators, to the social workers, and then we take the ball rolling. So again, know who's your team. So also, what's important, as well as getting, and thank you guys for being here, is knowing what the law is and reaching out to the others, so that I know within our organization, like I mentioned, the inpatient chaplain was aware of medical aid and dying. The team inpatient doctors are aware of the law. You know, the social workers, a patient will talk to them about it. Can I have it in a hospital? No, it's not allowed, but here's what we can do when you get discharged. So those things are important. Again, it's not again within our HPH system. Like I mentioned, I will reach out if a physician wants help on the other side. I will say yes, willing to help, and work with your staff so they understand the law. And as I mentioned, I've got the Excel spreadsheet. I don't have a template, but I'm the behind the scenes kind of knowing where are we with this patient in that part of the process. And again, I'm also there for the patient and the family and the staff as their resource as well. Next slide. So for the nurse facilitators and for us, that role can also be a social worker, just like how Jody and Susan work together. Sometimes it's whoever takes that lead. Most of the time, I would say 60% of our patients have gone through with the oncology social workers only and the providers. And then the other part, it's the nurse navigators. And then myself, mostly I work with the outer island patients if there's not because our oncology nurse navigators and have a limited, in terms of their time. So I help them a lot. So again, referrals, they'll help with who's going to be the help, the point person, who's your team, and then knowing who's the patient provider. So they'll work with the patients and say, okay, who's you're going to be attending? That's the biggest thing, because many of the PCPs are not necessarily, they've never had a patient request this. They don't know how to do the first steps, or sometimes they're willing but not willing to write the prescription. So they'll say, I'll do the consultant. So many times our navigators or social workers will take on that role and say, and do the work for the patient and say, I will call that physician, I will reach out to this other person. And so that's what their role is, trying to figure out who the providers are for the mostly the attending, the consultant. And then for the mental health consult, we use one of our Straub's psychologists, and she's pretty consistent about doing that. So that part is easy for us. Again, education. My role also, sometimes I've been doing a lot of one-on-one education. And again, with COVID, it's with Zoom. The social worker or nurse navigators will sit down with them too, and really explore, just like Dr. Miller had said at the beginning, listen. Why are they wanting to do it? What's their story? Listen to their story. Have that goals of care discussion, and yes, invite that person. It's not necessarily their family, right? It's their immediate caregiver. I had one patient in Kauai whose caregiver the last 3 years was his support person. So get them in the room together. Some patients totally will say, you know what, I only want this sister involved, but not this other family, even though they're close to me. And that's that patient's choice. Advanced care planning is important, getting their advanced directives on file, educate them about pulse, making sure the pulse is done, especially if they're going to die at home. And again, go through the processes and requirements of the law, because there's so many steps, they do get overwhelmed, as Jody had mentioned before. So we have to help them. Sometimes after, I will send them a little note and I'll say, okay, we've discussed this. Here's the information, the written request, etc. And then at the bottom, I'll say next steps. What's your next steps to get completed? The written request, final attestation letter later, and then follow-up appointments. Always double check with the patients, give that patient time, how they want to proceed. We have a patient who's gone through that whole process, and now she's ready to take her medication, but she's doing okay. She's an ALS patient. And so with her and her daughter, who's her support person, I've said to them, don't rush to get that medication necessarily. That's your choice. Some patients adamantly say, I want to hold that medication, so I'm in control and I have it when I need it, regardless if they use it or not. So always check in with them. How do they want to proceed? Do they want to have the medication now, or when they have a timeline? Medication introduction, we'll go through. They do. People want to know, what is this? Is this an intravenous? How do we get it? So they come, they don't know what the how they're going to take this medication. So that first meeting or the nurse navigators will go through the basics about the medication. So again, we do not have an outpatient pharmacist specifically for medical aid in dying. So the nurse navigators do that process. I do that process with them again. So just give them the basic education, educate yourself again, and then keep updated with the law on what's going on in the mainland, because they're moving California and Oregon, who's been doing this, Oregon for years, but know what's going on with the latest in medication and things like that. Work with Compassion and Choices as well. Next slide. Kind of mention patient, it is definitely patient driven. I kind of mentioned about the education, the resources, exploration. I would say I would spend at least 60 minutes with the patients when I did first do their first encounter. Sometimes the palliative, if I have our providers, will take a good 90 minutes. And just explore the reasons why, their fears and worries, their goals. Even right now, what is their next goal? Are they content? Is there any things, are there any family they want to get involved? So give that time for questioning and just listening, and then like Dr. Miller had said, review all their end of life options with them, get them involved with hospice for a lot of oncology patients, get them, see if they're eligible for supportive care, get them on board with that process too. Next slide. our role, just remember and remind your coworkers as well, and the people that you work with, and just to be non-judgmental. We have so many, and even as you meet up with your patients, they're fragile, and they're here. Sometimes it's a hard decision to make, and I tell them I so admire them. I learn so much from them. So come with open arms, and I know many of you do, and just to be non-judgmental, and just listen and seeing where they are. Again, providing in a neutral manner information. Department of Health forms, help them through. Even for our doctors, this is what we do for them. We spoil them a little bit. We spoil them a lot. So we help do the PDF for the basic information, for the Department of Health forms, for the attending forms, as well as the follow-up forms, and then print it and let them review and sign it. So we're responsible a lot for that. Check in again with the patient's condition timeline. We'll try to get all the appointments for providers within 2 weeks. Again, some patients do not meet that 20-day window, and they deteriorate or they decline really quickly. Hospice, I mentioned before, the available access. They have my cell phone number. You know, they'll call me, even if I'm right now, I'm away right now, and they still call me. But that's okay. You know why? Because I've worked with these patients and their family. And the last 2 weeks I've been on leave, and then basically 3 patients have called me, and I was definitely, because you've formed a bond and with that patients and their family, that you have to be there no matter what. Be there, and they know that they can count on you for anything before they're taking the medication. Even after, family called me last week and says, "Hey, Michelle, can we talk? You know, everything went smoothly. He was so at peace. It was beautiful. But now I feel so lonely," right? So yeah, I spent a good 60 minutes just with that caregiver, listening, sharing stories, you know, how did it go, you know, and what did they had for their last meal and things like that. That patient inquiry wanted McDonald's. It's like, what? He wants McDonald's? He wants a dairy? He wanted a shake. And I was like, I was kind of scolding them. I was like, you know, you're not supposed to have any dairy products, you know, you're supposed to have clear liquids. And the family's like, but Michelle, what does it matter? Just give him the milkshake and give him his chicken nuggets. But yeah, but these things will come up, and just be there for them. You guys are absolutely the advocates. That's why you're in this role in healthcare. So continue to do what you know is best. And then also your team, you got to support each other, no matter what, be there with each other. It's so, so important. And then one of my roles I do is debriefing. So I'll offer with the hospice, separately with the families or so, and the staff too. And again, I'm very important. I know Dr. Grube from Compassionate Choices always says, hey, you guys make sure you do debrief, because you don't realize it, but it is important for all of us to share how it went. Next slide. Like I mentioned before, our social workers has a huge role. Shout out to all of them listening if they're here. So thank you very much. And also the nurse navigators who's listened as well. I mean, the oncology nurse navigators and oncology social workers. I wouldn't be this process would not go anywhere without them. So again, thanks to the social worker, vital role. They take on the ball. They do the psychosocial assessment before they go to, we do palliative care referrals. If the patient's not mandatory, we offer it. But some of the patients who are kind of sitting on a fence, not quite sure, needs a little bit more goals of care conversations, or even with their family has some questions and not sure, that's when we'll do a palliative care consult. Advanced care planning, hospice education, etc. Thanks. Next slide, I think. One more. Okay, medication. So I'm not going to go through all the medication stuff that Susan did, but like I mentioned, keep up to date. Like right now, there's a new medication that California is using that they're started to use. So we're like, okay, just looking and seeing the time of death and things like that, the DDMA plus. So again, look at the patient's timeline, and we've had patients change their timeline, which is totally okay. Make sure, review their timeline, know what to expect. Again, we have a patient who's had the medication for over 6 months. The expiration date is 6 months. So I have told the patient, you know, technically your medication has expired. Still in that process, but this is a heads up. What we do is when we do print out, before we print it out in the computer, is to see who's going to pick up the medication. Is it the family? Make sure the name of the family, whether it be, you know, the spouse or the daughter, etc. And we put it and we print it out. We'll send a hard copy to pharmacy as well via certified mail and FedEx, just to make sure it gets there, because pharmacy needs to have that hard copy before they can actually make the compounded medication. As well as we'll give them a heads up, we'll fax it or even call them. Outer Island patients, I'm speaking more specifically for Kauai and Maui, because now I know that in Bagay Island, there's some clinics, the pharmacy over there, but we have to FedEx it over there from the pharmacy, we'll have to. So allow that time in their timeline to know when they can anticipate getting the medication and where it's going to go to. And usually goes to a person's home as well. Again, before a patient does want to move forward taking the medication, you're going to sit down with them the week before and go through it with them, with the patient and their support persons mixing the medication. Next slide. Here's our data. We've only had like 58 patients total, only 8 up this year. Just like Kaiser Permanente, 81%, a big percentage cancer diagnosis. I mentioned before, we'll do our outpatient, not mandatory, but palliative care consult. 55% of those patients have had a palliative care consult. And of those 58 patients, we have had them go into some kind of supportive services or directly full on with hospice service. 16 of our patients, neighbor islands, 12 of them were specifically Kauai, since we have Wilcox Medical Center. Of those 58 patients, 37 did complete their first oral request. Some patients did expire before the mandatory 20-day waiting period. 2 patients died naturally, and then we came down to 25 patients completed their second oral request, and we have some more pending this month. Of those, we had 17 prescriptions written, and you could see the breakdown with DDMP2 and DDMA. And just like Kaiser Permanente, we're using DDMA now. And 12 patients have ingested the medication and passed from it. Next slide. Quickly, this is a quick workflow that we have on the internet. Next slide. And you could see it's great for the staff. I love it. I wish I could say I did this, what one of my coworkers did it. So basically, if you press on any of those boxes, it'll take you through the step of the patient. Next slide, of what is needed, that is. So first oral request, written prescription. It'll give you like the pharmacy and things like that. Next slide. So this is an example. If I press on the box that says the attending reporting forms, it tells you exactly what you need, what you have to send in. Takes you to the link, mail this form into Department of Health, make sure it's scanned into our medical records. So very specific. Next slide. Thanks.
Thank you so much, Michelle. We're going to go now to Dr. Miller, who's going to talk about the medication itself, and then we'll go to questions. Dr. Miller?
Thanks, Sam. What are the medications? The medications that we now use are, the acronym is DDMA, diazepam, digoxin, morphine, and amitriptyline. Preparations before, every patient absolutely has to take 2 antiemetic drugs 1 hour before they plan to take the medication. If they don't do that, they will throw it up. absolutely guaranteed. What's involved in taking them? We talked a little bit, they really don't recommend having any dairy products, and probably NPO for the 6 hours prior to the time of ingestion. The medications are picked up or delivered to the patient in separate vials. They're all powders, and they when a decision is made to take them, the powders are mixed together and diluted in 6 to 8 to 10 ounces of water. I think more is better because it's easier to drink. And what does compounding medications mean? It's exactly that. They are compounded as powders. They're not liquids, and the powders have to be mixed together and then diluted. Next slide. So the pharmacist, we're fortunate in the Kaiser system because we can e-script the prescription directly to the pharmacy, the Kaiser pharmacy. I don't know that most of the pharmacists, at least on the outer islands, they don't necessarily always interview the patient, but they do counsel the patient and the family either right at the time that they dispense the medications or sometimes even before. Then they have to submit forms as well. Next slide. This goes over what I mentioned earlier. 1 hour prior, you two antiemetics. I use ondansetron and metoclopramide. This is a way that it can be given. Digoxin can be diluted separately and taken 30 minutes prior to the ingestion of the other 3 drugs. We don't do that at Kaiser pretty much. Primarily, I think it's an extra step that doesn't, just makes it more difficult for the patient and the family. The reason this was initiated is there was some research that suggested separating out the digoxin 30 minutes before the other 3 drugs provided a shorter time to death. We have not had a problem since we switched to DDMA, keeping them all together. And as somebody mentioned earlier, most of the patients have died within 2 hours, a lot of them a lot sooner than that. Next slide. There are some red flags. We did have one patient. Let me first say the standard of practice for medical aid in dying. We want the patient, hopefully the patient will die within 2 hours of ingestion. It's considered acceptable if the patient dies within 4 hours, but if it takes longer than 4 hours, it is considered outside the standard of care. So there are things that can cause a patient to have a longer time to death, and these are some of them. Problems with swallowing, with malignancy, gastroparesis, you can name it. If they have any of these things, including really bad ascites, it can delay absorption and prolong the time to death. The other thing is younger patients. The one patient we had that took 6 hours, he was 50 years old and completely healthy, except for the fact that he had a cancer, obesity, alcoholism, and if they're on high doses of morphine to begin with, that can delay time to death. Next slide. And I'm going to take it back to Sam, and that's it.
I think this is a Kaiser slide. It's our last, kind of the last slide. If you just wanted to do a summary of your experience as a team-based approach.
Oh, well, no, I'm not sure I can add anything. Jody and Susan have, they are angels of mercy for both the patients and me, the attending physician. We have a very well integrated system. It works well, and most of the time, our patients can get their drug within 21, 22, or 23 days after their first oral request. Whether they, again, something needs to be mentioned about this. The patient then has the option. They can take it whenever they want to, or whenever they're ready. My first patient, he waited 18 months and the medication was fine. Go back to that thing about the expiration dates on the medication. That's there for legal coverage. I'm telling, when I talk to patients about it, I tell them the medication is going to long outlive you. So that's not an issue to deal with.
Michelle, is there anything you wanted to add about a team-based approach?
I just wanted to say thank you again to my team. Without them, and also, like I said, I wouldn't be, this process wouldn't have been smooth. And also to you guys, the Compassionate Choices, for always being there, guiding us, giving us the in-service, and as well as the community and Kaiser Permanente. It's a team approach. I mean, we got to work together. I mean, we're so small in Hawaii. I mean, we have to depend on each other and our resources together. And I know more importantly, it's for the patient, and it's a struggle when the patient is not in HP system or Kaiser Permanente system. That's where we have the barriers that we haven't moved forward to. That's something we still need to address, because basically that's still a barrier. So, but yeah, thanks.
Thank you, Michelle. I got to say, Kaiser and Hawaii Pacific Health, you've both just done such a tremendous job of making it work and supporting patients, and really, really incredible. Thank you so much for all you do for your patients. We're just about finished. I did want to let everyone know because, and I know Dr. Miller mentioned it earlier, there was a bill that was inspired by the Hawaii Department of Health. It nearly passed last year, and then the pandemic hit, the legislature closed down, and it didn't get to. And so we had high hopes that it would get through this year. In fact, it passed through the Senate overwhelmingly with 21-4 votes. And unfortunately, it's been referred to 4 committees in the House, which is technically impossible for it to get through in time for the session, and is clearly an attempt to not allow the bill to go through the democratic process. It's incredibly frustrating and upsetting. And I know that's not what this webinar is about, so we're not going to talk about it too much, but I know they're, especially since there are nurses on this call, what the bill would have done is it would have allowed APRNs the ability to support patients as both the attending and consulting provider and as the mental health specialist. It would also allow the prescribing provider the ability to waive the mandatory minimum waiting period if the patient was unlikely to survive it. Oregon has made this amendment to their law, which Hawaii's law is based off of. And it's been tremendous. 20% of prescriptions written last year had the waiting period waived. They had about 80 more patients who were able to access the law in Oregon because of that amendment. And in fact, New Mexico just passed a medical aid in dying law. Compassionate Choices and others have been working for years and years to do that. They have a 48-hour waiting period, not even 20 days or 15 days. Hawaii actually has the most strict law of all the laws. We're the only state that has 20-day waiting period. Every other state has 15, except now for New Mexico, which has 48 hours. So hopefully we can get this bill passed next year. And if you would like to hear more about it, please join us on March 30th at 12:15 p.m. Hawaii time. We will be talking about the bill and what we can do during this time to try to make sure we're successful in the future. Next slide, please. We have some exciting things coming up. The Hawaii Department of Health will be releasing the report on the first 2 years of the Our Care, Our Choice Act in the next few weeks. And in fact, I believe it's on April 7th that the Department of Health will be sharing their findings, what's happened over the last 2 years. And April 28th, those are our next 2 CEU webinars. So tell your friends, come join us again to talk about this. Next slide, please. We have a plethora of resources on our website. I encourage you all to write down that phone number, 1-800-247-7421, or if you have my email address or Karen's email address, we can always help you find a mentor or someone. If you have any questions related to medical aid in dying, if you want a speaker, if you want a presenter to do grand rounds, whatever, we're happy to provide that. Next slide, please. All righty. We are nearly out of time. And so we are going to go through a few questions, but what we're going to do is we're going to send out an email with all the questions we didn't get to and those answers. We always think we're going to end early and we always go so long. So I apologize for that. The first question is, when are forms sent to the Department of Health? That's an easy one I can answer. It's within 30 days after the medication. Oh, their question is, within 30 days after the medication is prescribed or after 30 days. Actually, maybe I should let one of you talk about submitting the forms since you have more experience than I do submitting them. Does anybody want to take that one, Susan?
Sure. So it's within 30 days.
You want? Okay, thank you.
Yeah.
Can the prescription be written after 48 hours of the patient's written request submitted? Dr. Miller, do you want to answer that one?
Yeah. But they also have to complete the 20-day waiting period. Okay. So the issue would come up if I got the second oral request, but they hadn't submitted the written request yet, I can't write the prescription until we actually see the written request, and then I can write it 48 hours after we actually receive it.
And that all can happen within the 20-day waiting period, which is really important. So you don't need to wait an additional 48 hours after the 20 days. What is the current cost or copay of the medical aid in dying cocktail medication? Anybody know? Do you want to answer, Susan or Michelle?
Jody, do you want to? I mean, I think Jody mentioned, at least at Kaiser, we've seen it anywhere from 0 to a bit over 200. We're fortunate that we have a medical financial aid assistance program. So if people are eligible, they're able actually to get it for 0 cost. And then I think, as we mentioned, Quest covers the prescription as well.
And then for us, most of our patients, for us that we use the pharmacy on Oahu, it's about just under $500 actually. And a lot of our patients, we had some VA patients that would not cover it. HMSA, some insurance carriers may not cover it. So it's about $500. And then if they have to pay for FedEx charge as well for outer island, they have to involve that as well.
Thank you, Michelle. How can we best support clients requesting medical aid in dying outside of Kaiser if hospice declines active support and coordination of the process? That's a hard question. I don't know. Does anybody, Michelle, Dr. Miller?
My only comment, I'm personally aware of 2 or 3 community physicians. They're basically all oncologists who are willing to serve as attending physicians for patients who request medical aid in dying that are not their own patients. And that's about it. Sam, I thought that Compassionate Choices actually keeps track of who has been writing prescriptions.
I was going to add that so we will try to help anyone who can't find a physician. And we're really working on normalizing it. You know, we don't want people to have to come to us if they can't find a doctor to support them. But when we do get a patient, and it happens a lot on the Big Island, there are very few doctors who are allowed to practice on the Big Island from our understanding. You know, any healthcare system or hospice can block their physicians from practicing. And, you know, any physician can opt out. So this is another reason we really want APRNs to be able to support patients as well, to help support access, especially on the neighbor islands. But if you know anyone who's having problems finding a doctor, let us know, and we will do our best. We have helped a lot of patients find care, so that they can access the option. But we don't want to play this role forever, because it's not, you know, that's just not right. People shouldn't have to change doctors. So thank you for coming here today. I hope that this webinar was incredibly helpful for you. Just by being here, I think it helps normalize this practice, so that it'll be easier for patients to find the support they need. So thank you all. We are out of time, but we will be emailing you your continuing education credits and the questions and answers that we didn't get to. Thank you so much to our presenters. We are always so grateful for all the work you do and for sharing your wisdom with everyone. Thank you, everyone. Have a good day. Aloha.